patient safety programs. This is the second part, and today we shall be focusing on how to align frontline health workers to patient safety. And you have an illustrious panel, as you can see on the screen, and I will allow them to introduce themselves. We shall begin with Dr. Victoria to introduce herself. Tell us, Daktari, what you do at the Aga Khan University Hospital. This is one of the foremost hospitals that has really taken quality to the next level, up to and including getting international accreditations, several of them. So welcome, Daktari.
Thank you so much, Dr. Kira. Just a brief introduction. My name is Dr. Victoria Kanyeri Nairuti. As you said, I'm a medical doctor by training, specialized in healthcare quality and patient safety, with a master's degree in public health from the University of South Wales and a fellowship from SQHK. I currently serve at the Aga Khan University Hospital as a clinical quality advisor. Largely have supported the clinical departments, ranging from surgery, anesthesia, obstetrics and pediatrics, that is the maternal and child health. And I also serve as an internal physician surveyor for the Aga Khan Development Network. So I'm happy to be here with us all to share and also to learn from one another. Thank you.
Thank you very much, Daktari, and we really look forward to listening more to you on this very important topic. Our second speaker and panelist who is with us here is Dr. Lydia Nyangwencha, joining us all the way from Machakos County. Daktari, we welcome you to just give a brief introduction of who you are and what you do in Machakos.
Thank you, Daniel. Good evening, everyone. You have done really well to try and pronounce my name. Very few people get it right, so thank you very much. It's really humbling to be here. As you have been told, my name is Dr. Lydia Nyagwencha. I am a medical doctor by training from the University of Nairobi. I also have a master's in public health from the Kenya Methodist University. I majored in epidemiology and disease control. So at the county, I serve as a public health physician at Machakos Level 5, and also the quality improvement and patient safety lead, both at the hospital level and at the county. So what we do is try to bring together all the quality improvement initiatives and committees from IPC, AMS, MPDSR, the quality improvement and patient safety itself, and pharmacovigilance, so that we coordinate all our activities towards one goal of achieving better patient experience. I am glad to be here. So yes, that is me, but my special interest is in quality improvement and patient safety. It's really going to be exciting to be here today. Thank you very much.
Thank you very much, Dr. Lydia, and bringing that public health aspect. So we're not just looking at facility, we're looking at county-wide quality improvement initiatives, and we shall be really excited to get to learn more about how that is done. We also have with us Doris Kimbui from Kenyatta National Hospital, who is managing the clinical services at the Prime Care Center. Doris, please give us a small intro. What do you do? What does this entail at KNH?
Okay, thank you very much. I'm trying to bring my video on. Okay, sorry. As that comes on, my name is Doris Kanja. As you've heard, I'm the clinical manager at Kenyatta Prime Care Center, which is a business strategic unit for KNH. We are mainly domiciled on 9th floor and 10th floor. And I am a nurse by profession, a Bachelor of Science in Nursing, and my master is in business administration with a major in strategic management. And I am also a certified internal lead auditor. I do audits at the hospital on ISO 9001 2015. I'm a quality and patient safety champion. Here, I lead in terms of implementation of quality improvement initiatives and safety programs. And I'm really excited to be in this forum because I think as we discuss pertinent issues concerning fostering quality improvement through the collaborations and also innovations, I think it will take us to the next level as far as quality and patient safety is concerned. So I'm really happy to be here. Thank you.
Daniel, you are muted.
Oh, sorry. Thank you so much, Doris. Apologies that I was muted there. And I'm your host, manager, the head in quality at the Mater Hospital Network. We have the main hospital there in South Bay of Nairobi and satellite clinics around the county and some in outside counties. I also I'm a council member for the Society for Quality Healthcare Kenya, which brings together like-minded health professionals like the ones we have here in our panel and others who are part of the discussion today as participants to advance the agenda of patient safety in Kenya. And we associate also with other quality associations in Africa and also internationally, because this is safety knows no boundaries and it's a global movement. So to start off our discussion, we shall have a presentation from Dr. Victoria Ruti on how, giving us some ideas on how to bring frontline engagement of health workers in the matters of patient safety. Welcome, Dr.
Thank you. Thank you, Dr. Kira, for that. For the opportunity, I also want to say thank you to Dr. Kutoi and Dr. Salima Kanzi. I don't know if she's here, for the opportunity to share the presentation with you today. So I'll be taking us through engaging frontline staff in quality improvement and patient safety, looking at how the Aga Khan University Hospital has managed to do that and continues to strive to do better. So in the introduction, quality and patient safety is everyone's responsibility, not just the role of the management or the quality department. And healthcare is really a team sport. It has to have multiple players for us to be able to achieve safe and high quality care. And there needs to be coordinated efforts from all the staff across all the disciplines and all the levels. And this is irrespective of the cadre. So every team member, ranging from the clinicians to the support staff to the allied healthcare workers, contribute actually to creating a safe environment and preventing harm. So why does engagement matter? One, the aim is to achieve better outcomes, whereby when you have engaged and valued staff, they then deliver high quality care with fewer errors. They also become more vigilant and proactive and committed to patient well-being, leading to better outcomes. And remember, at the end of the day, they interact directly with the care processes. For those of us who might not be really at the front line, you might create processes that are really not suitable for this staff. But out of their engagement with these processes and also with the patients, they get to know what works and what doesn't. They see the day-to-day risks. They identify the workflow gaps that exist, and they therefore can drive creative and practical solutions, whereby they are the eyes, ears, and the problem solvers of the healthcare system. What are the components of staff engagement there? For one, there needs to be a shared mission. We need to have a shared goal. And this comes from aligning the team around a common vision of understanding that zero harm and excellent care is the way for us to go. Every team member, raising from the nurses, the physicians, the allied health support staff should understand and embrace the mission of delivering safe, high quality, zero harm care. Daily the purpose. So once we say to achieve zero excellence, and this comes from leaders continually communicating how each role contributes to the bigger purpose and recognizing how actually small actions lead to safer outcomes. The cleaner that is cleaning the patient's bed needs to understand why the disinfection process is important, how the mixing of the disinfectants actually leads to reduction of, for example, hospital-acquired infections. The third is staff involvement in decision making. When we engage the frontline staff in problem solving and improvement efforts, they then, since as we said, they are the experts in how the work really happens, and they are very essential in identifying gaps and driving sustainable solutions. So we've said again and to reinforce, they are the true experts in how the work is really done. They understand the workflows, the challenges, and then how do we do that? One, involving staff quality and safety committees and actively seeking input on improvement initiatives. For example, how do we prevent the medications? And that, for example, an error happened, but there's probably two drugs actually like, and they have been missed in the lookalike list. Patient falls, they get to interact and know what are the pitfalls, for example, in the environment, or in our fall assessments or risk assessments or in interventions that actually predisposing patients to falling, or what is leading to delays in care. So when they are actually engaged in problem solving and in process design, they take ownership of the outcomes, and they are actually active participants in driving improvements. However, this can only be possible when we have psychological safety, and this is the speak-up culture. So speak-up culture is an environment where everyone feels safe to voice ideas, concerns, or mistakes without fear of punishment or humiliation. And this is by leaders modeling openness, by discussing errors transparently and not in hushed tones, encouraging dialogue. And even when it entails now critiquing probably how we have been doing things and responding supportively when concerns are raised. And evidence shows that teams with higher psychological safety, they discuss and learn from errors, leading to stronger teamwork, better communication, and improved team outcomes. What are the barriers to engagement? One, workload. If our staff are overworked, if they're burdened with a lot of work, they have to juggle high patient volumes and long shifts, then they have little energy or time to participate in improvement or safety initiative. Where the challenge is actually further amplified in areas where we have inadequate staffing, to which eventually does make even the most enthusiastic staff to feel disengaged. A culture of blame and hierarchy. In environments where we have steep hierarchies or blame culture, staff may fear that speaking up about problems could lead to punishment or backlash. And what you find is that safety events keep on coming up. You keep on trying to look for solutions, and nothing is actually sustainable because the real experts on the ground are not in a position, or they are not being empowered to actually speak up and point exactly where the problem is. When team members feel ignored or blamed, they withdraw, and the silencing valuable feedback and learning opportunities. So you said lack of psychological safety is another barrier. When team members don't feel safe to voice concerns or report mistakes, unclear communication, whereby once they report, there's poor or inconsistent feedback or communication, leading to confusion, there's mistrust and disconnect between the leadership and the frontline staff, lack of support or recognition, such that when they actually put in efforts, they go unnoticed or unsupported. The motivation eventually declines, and the engagement in the staff in the quality and safety initiatives eventually diminishes. So how is the Aga Khan University Hospital, how have we been able to embed staff engagement in daily practice? One, having, for example, nurses, physicians, and when you talk of physicians, we do have the faculty physicians who are full employees of the hospital, and we also have the private physicians, we have the allied staff, and since we have trainees, we have the chief resident being able to participate and be a part of the departmental quality improvement committees. So how the quality structure is set up is that every department does have a quality improvement committee where they sit and actually discuss the performance of their indicators. Therefore, having these participants there actually then brings real and practical insights from daily operations. They're able to tell you, we are not able to do this, we're not able to navigate this feature, for example, now that we've gone into EHR, and you're therefore able to hear the challenges that they are facing from the actually what we call the horse's mouth, involving staff directly in identifying problems, proposing solutions, and implementing changes. For example, right now there's a Kaizen project in terms of improving the waiting times in our outpatient clinics, in our pharmacy, and in the radiology section. And you find we have staff who are involved, including a unit coordinator, a unit assistant, a healthcare assistant, to be able to tell you what are the gaps when it comes to registering of patients, what are the gaps when it comes to finding out why patients come late for clinics. The leadership might not really be able to identify those challenges if you cannot hear them from the person who's carrying out that task every day. Fostering multidisciplinary teamwork for system-wide improvement, having different cadres come in and look at a problem. Providing training and mentorship in QI tools. For example, you'll find we do train the staff on the PDSA cycle, the RCA methodology, and FMEAs, and you find that in each and every root cause analysis that is done, you must have the sequence of events people. These are the care teams that took care of these patients. And we've actually come a long way in terms of encouraging participation from these team members and not fearing to be able to share what really actually happened or what do they think actually led to the problem. And at the beginning of every RCA, I know my supervisor, Dr. Kanji, actually takes it upon herself to emphasize each and every time that we are looking at the system and not the person. Looking at having team members in each and every FMEA project, each and every CQI project, and actually you find they do bring in very valuable insights. Like today morning, we did have a drill somewhere in our emergency department. And at the end of it all, and there was a debrief, one of the nurses said actually having action cards on being distributed on the task of each and every team member when it comes to the drill will be helpful. And everyone actually was really wowed at, because that comes from the person who's there at the ground responding to an emergency if it occurs. Sharing visual tools and checklists, display of safety metrics. This is displaying of the unit performance indicators such as hand hygiene compliance, number of patient falls, for example, medication errors in staff areas. These are the staff lounge areas, and these staff therefore are able to know whether they're actually improving or the trend is going down, and they're actually able to be aware of where their departments or their units are actually struggling. At a glance, this does engage the staff by making performance transparent and the goals clear, and they see both the progress and the gaps visually, reinforcing purpose and prompting immediate action. Use of checklists for critical clinical tasks such as surgery, medication reviews. If you're doing appropriateness review, there are checklists where staff are able to know these are the things I need to check. For example, if it's a ward stock, before we went to EHR, the staff had to do the appropriateness review for the ward stocks that are there. And therefore, they're able to tell that these are 1, 2, 3, 4 things that I'm supposed to check. If we go to the surgical safety checklist, the staff actually participate in doing the sign-in, the time of the sign-out. And this is with an aim to actually reduce any surgical errors that may occur. Incident reporting and learning is another aspect, having blame-free reporting, encouraging staff to report errors and near misses using simple and accessible tools. And we currently have an incident reporting system on EHR where staff are actually encouraged to log in and actually report an incident. And we have tried to make this non-punitive, and actually to encourage this, you have a report that is sent each and every quarter to departments, showing how many incidents did each department report. And you find that actually reporting of incidents is actually encouraged. The other thing we do track is the closure of these incidents once they are raised, and provision of feedback to the staff. When I raise a concern, I should be able to get feedback and appreciation for the concern that I actually raised. And what we've noted is that the reporting has actually gone higher. The other aspect of reporting is conducting a learning culture, as you said, multidisciplinary reviews to identify system causes rather than individual blame, sharing lessons. So when we have done all this, reviewed the patient safety events, sharing back to the staff during a departmental forum. For example, we had this number of patient safety events. These are the action plans that came in from the event. These were the corrective actions. These are the preventive actions, so that we are able to promote learning and prevent recurrence. When we come to culture of safety, the staff do participate in a biannual culture of safety survey that is done actually by an external provider. We do encourage them in each and every department to be able to provide this information. And once the feedback is shared from the survey, we do share that feedback with the unit leaders and also with the departments to be able to guide on areas of improvement. And currently, I know the institution has a committee that is looking at this feedback from the culture of safety. And once the improvements have been put in place, then the staff are given feedback. Recognition and awards, acknowledging efforts. Implementing programs that recognize staff contributions to patient safety and quality improvement is important. And I know as a start, for the last 3 years, the organization has worked towards rewarding staff during the customer service week. Since customer service, a patient experience is a big part of actually quality. And this year they took a different turn where they actually rewarded teams that had done well, teams that actually pulled in together to be able to serve a patient. And there was a team that was rewarded for being able to take care of a baby who was brought into the country, and the parents could not be able to afford the care. And people actually ended up contributing diapers, contributing toys for the child. And the theme for this year was Mission Possible. And you find that encourages staff and teams to be able to do better next time. Positive reinforcement, as we say, celebrating improvements and safe behaviors, whereby it boosts morals and makes safety personal for the staff. And remember, where we support people and they feel good about that, then that actually gets repeated. So when you look at sustaining engagement, we are clear we are not yet there. And we still aim to integrate engagement into everyday operations. We are currently updating staff during departmental forums, seeking feedback on how we are doing, providing an ongoing treatment and development. We now have a simulation center whereby staff do go there and actually get to practice physically some of these things, like if it's delivery, in order to be able to prevent perineal tears. You have a patient in a HDU setup so that they're able to practice these things and be able to have practical skills. Setting evolving quality and safety targets, whereby if we find we probably have set an indicator and we've been at 100%, going back and looking at, are we able to set that, give ourselves a bigger challenge and set the target further to be able to maintain the momentum and inclusivity. Looking at regular communications, and at every year, every department sets themselves out through a plan to look at how will you engage staff this year. And every unit department is actually mandated to have departmental forums, and that is actually evaluated at the end of the year in their quality plans. Visible leadership commitment is a big pillar when it comes to staff engagement. So having senior leadership team present during the leadership rounds to be able to reinforce visibility and accountability, to be able to even engage the staff and get feedback on what are the challenges and the areas that they are actually doing well. So in conclusion, every role matters. Frontline staff are the driving force for safer care. Your ideas and actions save lives, whether it's a nurse double-checking a narcotic drug before giving or after giving, a lab technologist communicating a critical value. And together, we aim for safety. Let's make quality and safety not just an event, but an integral part of our daily operations. A shared commitment embedded in everything that we do. Thank you.
Wow. Hey, such an impressive talk, Dr. Victoria.
Thank you.
And I shall be getting back to you, give you a chance to breathe. I know there are many questions that are awaiting you. I'll encourage participants, you can put your questions in the Q&A, and then we shall be able to read them out and address. So as we wait for those questions to roll in, I'll just begin the panel discussion by inviting Dr. Lydia to give us a county perspective on how we have gotten very key insights from Dr. Victoria on at a facility level, how staff are getting engaged. But now Dr. Lydia, in her brief introduction, had informed us is doing this at a county level. So Dr. How do you bring this staff engagement from a county perspective? Over to you.
Thank you, Daniel. Thank you again for the opportunity. And Dr. Victoria has done an awesome job to discuss with us what we do at the facility level. So imagine we are trying to transition that at the county level with several levels of facilities, maybe a level 5, several level 4, several level 3. And the aim then is to make sure that we're having standardized practice happening across all the facilities within a county. It's a daunting task, but we are glad that we're here. We are glad that the conversations have started, and we're glad that we are laying foundations, especially as we wait for the patient safety bill to be passed. So we are starting the journey, and we're doing well. So the issues are just the same. I'll try as much as possible not to discuss them at the facility level, but try to broaden them so that we can see how we can do that on a larger scale. So as Doc said, the most important thing when you're running it on a county level is having leadership and management buy-in. Because now you realize the people who own the money and the decision makers and the people who will make your budget don't necessarily have information on quality improvement. They have not practiced in the field. And so now you have to convince them that it is important to spend money on quality improvement. I tell people, quality improvement, patient safety is mostly a spender. They would not generate much. So we have to convince them that it's actually important, because in the long run, then it's going to improve the patient experience, the quality of care, and it will actually cut the costs in the long run if we are practicing quality healthcare. So that is the most important part, that how will leaders engage frontline staff? The leaders themselves have to be very aware of the impact of quality improvement and patient safety on the overall healthcare system. That is the most important thing. And I think that's the biggest hurdle, because now once we get past that, then we can be able to have these programs and budgets implemented, and then we are able to move forward. Now, another thing, as Doc says, you have to involve all the stakeholders. So how do you do this at the county level? Is that first of all, you begin with capacity building. Yes, you might have a few members trained in level 5 hospital, some in level 4, level 3 have no idea what quality improvement is. So if they're having to communicate among themselves and provide specialized service, and patients have to move within the same county, they all have to have the same knowledge and understand why they need to do what they need to do. So it is very important that capacity is built, very important that there is collaboration in everything that is happening, and it has to be done on a bigger picture, so that now we know if we're building capacity, where are the gaps and where do we need to bridge, and it has to be very, very data driven. All right. But what it does is that it gives people a sense of purpose, knowing where I am in a level 3 or level 4 facility, I can give the best service as level 5 is doing to the best of my ability before I'm able to release this patient. And therefore, even when the patient gets to the higher level of the facility, the care was optimum, the complications are reduced, the mortalities and the morbidities are also taken care of. So it is important that all these things scale down to everyone else. Another thing is this systemic thinking, so that you understand you're running a healthcare system That is not dependent on one facility. You know that what happens at a level 3, level 4, level 5 hospital, what happens at a level 3 facility, whether it is a complicated delivery, will have an impact on the overall care of the patient, whether they get to level 5, so that you're not thinking, as long as I've referred this patient, I have solved the problem. So how does that happen? What we have tried in Machakos County is that if, for example, in our MPDSR initiatives, if we have a patient that landed at level 5 and unfortunately had a complication or a mortality, and we need to do an audit, we don't just do it at level 5. So we will start from where the patient came from. So the team that referred the patient to us will give us an account of what happened with the patient. We'll follow through the transport to the level 5 hospital and then what happened. And we'll discuss together and see how best can we then improve and respond adequately to improve the patient outcome. Another thing I would say is that we need to encourage continuous, intentional efforts other than thinking that we need to solve a problem and arrive at a destination. When I look at quality improvement, I see it as that scale, that ladder that we used to climb on the mathematics textbook. You move from class 1 and then you step to 2 and then you step to 3 and then you step to 4. Like, we have to be very patient with each other, even on a higher facility level, knowing that the ones who are below us are learning, and we can only just encourage them to continue to improve on their practices, encourage them that it is a journey. Just because it didn't go well this time, it might not go well next time, but as long as we continue to operate with our standard SOPs and standard procedures, we will grow and we will get better at it. Something else I want to say is that these things have to be very data driven. When you're working in a very large scale county, incident reporting is not as easy as it happens like where Dr. Victoria Nairuti works. An incident report would come to you as a social media post or a complaint through the media. It becomes very important that you go down and do a root cause analysis, realize where the issues are, set your objectives well, and have measurable outcomes. So that way you are able to know where the issues are in the system and fix them. Otherwise, we continue running helter-skelter and managing emotions, and the system does not improve at the end of it. So the challenge is we really need to manage the emotions and try as much as possible to be very scientific with what we do, and have clear timelines, have clear objectives, be very patient with ourselves, and very realistic at what it is that we need to improve in. So I think those, yes, would be the best strategies, just combining on what Doc has said, on a larger value, on a larger scale, to be able to implement these things on a county level. Thank you very much, Doc.
Thank you. Thank you very much, Dr. Lydia, giving us a county-wide perspective. It's not always easy, especially when you're when used to a facility level focus, to think broad. And we now appreciate what it means when we're asked to send some reports or participate in maybe county-wide MPDSR. I think now we will be more cooperative. So still on looking at the public perspective, but now at a facility level, we have Doris, who is joining us from Kenyatta National Hospital. And Doris, I would like to pose this question to you. In a public sector setting, facility level, how do one balance the need for standardization and consistency with the need for frontline staff to adapt and innovate in response to local challenges and patient needs? Putting that ideal standard and knowing that there's a need for adaptation and innovation to the local need. How do you do it in your experience at Kenyatta? Welcome, Doris.
Thank you very much, David. So when we look at it from our perspective, I like what Lydia has talked about. She's really brought it out very nicely, especially about having the systemic thinking and also looking at quality in terms of a journey. And also recognizing the fact that in the public sector, most of the time, issues will be brought up on social media or as complaints from clients, which in actual fact would, of course, water down the aspect of looking at maybe an error in terms of a learning, your learning curve, vis-a-vis looking at it from something that you have done wrong, and so it is punitive. So in our setting, we are actually looking at how we can balance standardization and consistency to look at it from a point of view where we bring in the aspect of flexibility. What am I talking about? For example, when the standards that you set in terms of quality bring out, you've set standards, yes, and this is exactly what you want to follow through. For example, you have things like standard operating procedures or guiding, the work instructions and all that. And these are meant to set a particular standard for us in the hospital. But now you bring in the aspect of flexibility where, like what Victoria was talking about, engagement of the personnel, such that you bring in an aspect where, yes, this is the standard. However, we are cognizant of the fact that these are maybe the patients, the number of patients that we usually receive here, the volumes, it is different. Maybe the staffing levels, all those dynamics, you put them in place. And now you're engaging the staff in terms of how do they bring out the aspect of innovation and also thinking through that process so that they bring out something better. I'll give you an example that what happened recently in our facility, where we've been having like we are a referral hospital for level 6 in the hospital in the country. And then what happens is that there is a traditional way that patients would flow into the accident and emergency and how they are treated and how they are received by the healthcare workers and all that, they flow. So when a platform was put for us to think through, how can we make this more efficient? How can we make this better? There was ownership of the whole process. And right now, the flow of patients has been changed. The dynamics in our accident and emergency has changed. In fact, even the name of the center has changed to International Trauma Center. Why? Because the people who are working there have actually owned the process and they have designed the area such that they are able to address the needs of the patients as they come in. So what I'm trying to say is this, that when we build trust and engagement amongst our frontline staff, what happens is that what starts as one simple principle ends up into improving learning and learning culture in the hospital, and it improves the engagement of our staff. And so they're able to employ these innovations because they are owning them. And because it is very flexible in terms of this is a standard, yes, but how do we work within this standard to make this, to own this process or to own this activity that we are doing? So that has really enabled us to be able to be more innovative and to also be more productive in terms of how we are doing our processes and procedures. I think the other aspect that has really come out is the aspect of positive reinforcement. And we have seen this happening, especially when we create teams. Like, for example, when we have teams like quality improvement teams. And when you bring in such teams, you put people together, they sit down and look at a process, and you see that they come up with suggestions which are in line with the guiding principles that have been set by the organization or even by the team leaders. And then you find that people want to really get involved. For example, like at Kenyatta Prime Care Center, KPCC, where I am, we have quality improvement teams. And in those quality improvement teams, you find that they participate in things like hand hygiene. And there is the peer-to-peer review where we are able to audit one another and to also look at like having a buddy system where you're supporting each other in terms of, have you washed your hands? Are you doing aseptic technique? And you see, that has really helped us to be able to keep connecting with one another and realizing, hey, you need to wash your hands, because if you don't wash your hands, then we are transmitting infections. I see that really helps to be able to create, to implement these standards in a more flexible way, other than the bureaucratic way of, this is a standard, you must follow it this way and that way and that way. So I think in a nutshell, I'm really in support of the aspect of engaging ourselves and also putting a platform of a culture where people feel safe to be able to interact and also to bring out their innovative ways of doing things. So yeah, I think that would be my contribution to that discussion.
Thank you very much, Doris. And we are really impressed with the major changes that you're instituting at Kenyatta National Hospital, and bringing out that aspect of the positive energy that health workers have, and it's just a matter of tapping into it. And you've really given us intuitive ways of tapping into that resource that is actually present and they are possible. Points that are coming in, great insights, Esther Sankale, very appreciating that. It's also Christopher Osire, and also asking for slides. We shall be asking the presenters if they're willing to share that. And yeah, I think Dr. Victoria, I have a question to you, but also I'm seeing some questions on the chat. So I'll ask you maybe to handle both as we go around. You mentioned in Aga Khan, the EHR system, you've mentioned severally in a few of the examples you're giving. And how have you used technology, really, facilitate quality improvement efforts? How energy of frontline staff to bring about quality improvement, and what are the key considerations for a successful implementation? So, and as you answer that, there's also a question here. Let me see, you're really coming in quite fast. Great presentation on the aspect of sustaining engagement, also share what has not worked. And that's from Dr. Okutoi. So maybe you can handle those two as we line up the other questions. They're really flowing in quite fast. Karibu, Daktari.
Oh, thank you. So in terms of technology, I must say we have been a bit, it's a big network, so we have been a bit slower to that. But we launched EHR in 2022. Did bring in a couple of challenges, I must say, in terms of first even working with the staff to understand what are the challenges in terms of using the EHR, what are the limitations, and what could we have made better. So in terms of that, we actually had teams who have been trained, who are frontline staff, to go back and support the teams in the departments in terms of using EHR, and also being able to access it from everywhere and anywhere for the physicians to so that they can document or be able to see patients more easily and more in a more flexible manner. So we, apart from EHR, we are looking at having clinical decision support tools. Currently, we're implementing order sets, and we sit down with remember again, the frontline staff are the experts. I can only facilitate a discussion. I'm not an obstetrician. I am not a surgeon. So sitting down with them to understand, For example, if a patient comes in who has premature rupture of membranes, what in the management of that patient using EHR would make it better? Building order sets such that by the click of a button, all the orders for that patient have actually been documented. We are still looking at having real-time dashboards. We still have not yet gotten there. In terms of that, simulations, as I mentioned, is another aspect. So setting up a simulation center whereby we are simulating a maternity ward, we are simulating an ICU, we are simulating HDU, we are simulating accident and emergency, and the staff are actually able to interact with these settings on one-to-one basis. There's actually, when I visited there, they're actually even doing 3D printing. So I can say as far as technology comes, that is where we have gotten so far. On the second question of what has not worked, remember, quality is relatively a new phenomenon, even for an institution as Aga Khan that has done JCIA for years. And at the beginning, the concept is had not been clearly understood, but I must say JCIA and even the institution's priority of actually achieving JCIA and continuing to do JCIA has improved the perception that staff have about quality. It's no longer a feeling of it's being pushed down my throat or I have to cram what is patient identification. Now you find there's more buy-in. You find that now staff are engaging better, and especially when now there's recognition, you find that people actually want to do better. It is now it is more satisfactory to actually hear or sit down and find a staff come in and talk about a continuous quality improvement project. So it's not really coming from quality, but coming from them. So what did not work is, one, pushing people to do things at your pace. As I usually say, staff have to understand what is the benefit to them first. Remember, we are all human beings. I need to understand what is the value to me before I can be able to actually support and engage in this. So sitting down with staff for them to have a clear understanding. If they're not understanding what is a CQI, you have to go back and sit down with them and take them through it and not tell them you need to have this. So that is what has worked over time. Having top-down communication did not work, but actually having engagements worked. Having staff engagement forums where staff actually give feedback on what they feel in regards to relating with the process works. So in a nutshell, I think that the communication, having communication both down up and not really top down, actually has helped improve the engagement.
Thank you. Thank you very much, Dr. Victoria. And even sharing with us what didn't work. Someone may imagine in a private facility institution, everything works. And thank you for sharing on that. There are a number of questions for Doris in the project of accident and emergency. Juguna is asking, Doris, did you have to change the whole accident and emergency staff in order to change the old traditional culture, or how did you manage to get the staff adopt quality? So how did you manage that culture change? That is from Juguna. And also Lydia is asking, looking at patient flow enables us to identify bottlenecks in the patient's journey, especially in complex health systems. So Doris, what challenges have you and the team at KPCC encountered when aligning patient flow? So those two questions to you, Doris, about culture change and the challenges in bringing this about. Karibu.
All right, thank you. Those are very good questions. Number one, I think I'll tackle the culture change aspect. And of course, we all know that change doesn't ever come easy, and people will always resist when change is brought. But I liked what, again, Victoria has said. She's talked about a change that is not coming from the top down, but coming from the down top. So one of the things that has happened, and no, we did not have to change everybody in the accident and emergency especially. We have not had to do that because in any case, we are already, our resources are quite stretched. So what has happened is that we've had to work with what we have, but change the strategy. In a nutshell, people will always respond and they will always support something that they have created. So when you open up a conversation where, guys, what do you think? There is a lot of, maybe, let's say, for example, the example that you were given was, there is so much congestion here. What do you people think that we can do better? And the ball is thrown back at the team. What happens is that what actually happened to us was that people started thinking about it and they realized we do actually have something that we can share, that we can give. And the more we got engaged, the more we wanted to own the process. So it has actually made it much, much easier, even though, of course, there's always that aspect of resistance to change. The fact that the changes were thrown back at us and we embraced the change and we decided, okay, we can actually change 1, 2, 3 things here and there. And it actually has been supported and we can see progress happening, has really empowered us in terms of adopting a culture that of change and also a positive culture towards a change. So for us, we have not really changed the staff. And even though maybe 1 or 2, but by and large, what happened was that there's that conversation where the ball was thrown back at us. And we just decided, okay, this has been thrown back at us. How do we work it out? And that has really helped in terms of owning the processes and also engaging even more to make the place better and better. I didn't get the second question. Could you please repeat it?
The question was related.
Yeah.
This was actually from Lydia. Just a minute.
Yes.
It was. So you're asking now. Lydia is asking C. Just let's see. What challenges have you and the team encountered with aligning patient flow? So it's a question of patient flow in a complex health system. What challenges have you and the team at KPCC encountered when aligning patient flow?
One of the biggest challenges that we have encountered is the number of patients. At some point when we were engaging and the change and adopting the new changes that we were making, we had an issue in the county hospitals, and so there was a major influx of patients who came in. So you see, we were thinking about a specific number of patients, the usual numbers that we get, and now we have to deal with a massive increased number of patients, more than 100% of what we are used to. So that affected that change. And also in doing patient flow, sometimes you may need to do a little bit of some infrastructural changes. And so with infrastructural changes comes with issues to do with the budget, issues to do with other resources that you had not planned for. But I think one of, in spite of all those challenges, that the fact that we had visible leadership supporting us and encouraging us to keep running, and also ensuring that whatever was required to make the changes was available, that has really come out very clearly, and it has helped us in terms of implementing the changes. So we had to deal with massive number of patients, both at the KPCC and also at the main hospital, and that was a big challenge for us to be able to do the patient flows. But we thank God it is work in progress and we are doing well, and that has been good.
Thank you very much, Doris. We are really amazed at how this is happening at the public hospital, KNH, KUTRH, and also MTRH. You're really inspirational, and expect many people coming to benchmark with what you're doing.
Look forward.
And all right. So there are two questions here that I would like to direct to Lydia. The first is has to do, actually, maybe I don't know how you'll combine them. One, Dennis Nyakundi is asking, what is the current nurse to patient ratio to achieve quality patient care? Maybe you can even ask, do we still use nurse to patient ratios? And together that, how with limited resources can we improve patient initiatives led by frontline staff? And what are the potential trade-offs? So with limited resources, how do we, limited resources such as limited staff or other resources, how can we push these initiatives? And what are the trade-offs that are involved in that? To you, Dr. Lydia.
Thank you, Doc. Thank you for having me back. Yes, in the public sector, especially with devolution, our biggest problem is resources in their amount and their allocation most of the time. So there are so many needs, very little money, a lot of conflicting interests. So keeping the balance is it's a very difficult, it's a seesaw. So you have to really be very clinical when you're doing that. But where should we begin with a few resources? We begin by maximizing the resources that you already have. Because sometimes you keep asking for more and it doesn't come. So the best thing you can do is try to maximize what you're getting to get the best effort on what to do. So how do you do that? We will not overemphasize collaboration with the frontline workers when it comes to decision-making and allocation of resources. So what happens is, let me give an example. You have a cancer center. You need a PET scan, you need a radiotherapy and a cryotherapy machine. And they are not there, and you have patients with all those needs. So then if you get down to the person that's giving you the front line, they'll tell you, now this takes priority over this because of ABCD. And therefore, so then when you're making your decision, as I have commented, you then use a prioritization matrix and realize, if I put my resources here, I am able to get maximum effort and I'm able to get high impact with a low effort on this type of project. So you really have to maximize your resources, whether it's money, whether it's equipment, whether it's human resource. What that does also is that it boosts a lot of morale, because people realize that their opinions matter and they care, and therefore they continue to give you feedback. And as you get feedback, then you continue to improve on how you're making your decisions. Another thing is we need to simplify processes in public service. Public service has so many things going on, so many segmented things at the same time. We could all be doing the same thing with one aim, but we're doing them so differently, so many processes, that by the time you're getting to the goal, we have lost time, we have lost money, we have lost even human resource. People are tired, they have transferred, and the process is still running. So we really need to simplify processes on how we handle these things. What we have done for us, we realized that we have an unspoken rule on how you contact a first and second and a third on call, and by the time the third on call is getting the information, the patient has been sitting here for an hour. So like in our maternity unit, we've implemented a system where if the patient is coming from Mwala, as you call to refer to level 5, you're also calling the consultant on call in level 5 with the same information you've given to the people receiving the patient, so that if they understand that this is an urgent issue, they're already on the way as the patient is coming, so that by the time they get there, they're getting the highest quality of care, and people have already organized themselves and they have arrived. So that has really worked for us. The other thing is that you have to do skill-based allocation. You have so many people, there are instances where you get a midwife managing internal medicine patients in the ward. It is a wasted resource. You get the best people giving the most efficient services and improve the quality of care if they are best trained in whatever they do. So in the allocation of the resources, yes, with all the other interests aside, we try as much as possible to ensure that the person that is in contact with the patient has the highest level of qualification. at that particular point to give the highest care. That is just how you can use what you already have before we start saying what is the patient-nurse ratio. Let me just answer that now before I proceed. It's actually 1 to 4. It's impossible in public service to get one nurse taking care of 4 patients. It's going to be impossible for us to get there. So we really have to use what we have adequately. The next thing is we really need to start leveraging data when we're planning in public service. And we need to get to the point where we are doing strategic prioritization. So I am glad that in Machakos County, we are planning to have a county strategic health plan, so that now, as we plan these activities, we are aiming towards a certain vision and a certain mission, that not everything keeps popping up here and there, and we keep doing knee-jerk reaction. So it looks like we are really not coordinated in how we are handling our issues. So that is actually what I think can happen. But as I have said, we need to think process efficiency. Process efficiency, reduce wastes, timely interventions, optimize what we already have. You asked me what are the trade-offs. When we start talking about trade-offs in quality, I think we already start talking about compromise, and it's a difficult journey. But what we are realizing is that we can actually have on-job training within the public service and improve. I am amazed at what COSESCA is doing. So what we are doing is we are having training to specialized care within the facilities while you're still providing services within the same facility. So those kind of partnerships are really helping us maximize on the use of resources instead of sending people out, having them paid, but still having to find a way to meet that budget need. What else? Collaborations. We have an amazing collaboration with the Aga Khan University Hospital for our cytology and histology at a bit of a discounted cost for our patients. So it helps us meet their needs where they are, while at the same time providing them the best quality of care that you can get. Those kind of collaborations are the trainings we can begin to think about private-public partnerships and on-job training. Another thing we can do is benchmarking. You would be glad to come to KNH and see what has worked for you that we can do with the resources that we have so that we can maximize on the quality of care that you're giving to our patients. I think I will leave it there for now.
Thank you very much, Dr. And really, you're an expert in working in public sector and leveraging the resources that are there to deliver quality. So there's a very specific question here, both to Doris and Dr. Victoria. How has KNH and SQHN aligned, so Kenyatta National Hospital and Aga Khan University of Nairobi, aligned the quality program with academic programs, especially with undergraduates? We are talking about frontline staff. We have students who are in training and aspiring to join the frontline staff. How are you engaging them? Maybe we can hear first from Dr. Victoria, private sector, and then Kenyatta National Hospital. This question is from James Rotich.
Thank you. So that's a very pertinent question, and it comes at a very timely, in the right time. So for this reaccreditation for a joint commission, which we are going for in November, we're actually going for the first time as an academic medical center, meaning now we are cognizant that we do have medical students and we do have trainees who are now the residents, and we also do have fellows. So how have they been incorporated? One, their orientation is very clear on one, having an orientation on the quality and patient safety program, whereby they are taken towards through IPSGs, incident reporting, IPC practices. The other thing is that these trainees are actually involved in things like data collection for either clinical practice guidelines. They are involved, as I said, in the quality improvement committees. So you'll find, let's say if it's the residents, they have one or two of them who do sit in a committee in each and every department. In terms of ensuring quality of care, they actually have competencies that determine the level of supervision that they require, and these are evaluated regularly so that you find that they are assigned competencies as they progress. There's a lot of oversight in terms of them practicing within their competencies and within the required supervision. Then we do have, let's say, if it's entries on the patient records, you find like for the residents and even for the fellows, the consultant or the consultant actually is mandated to countersign each and every entry that they do make in the patient's file to acknowledge that they are actually in agreement with the plan of management, and the expectation is that there should be consultation. So in terms of involvement of that is how we have managed to do that so far. Thank you.
Thank you, Doris. And sorry. Thank you, Dr. Victoria. That's amazing. I think it's one of the first times you're hearing students being taught quality as part of the initial training. So let's hear from Doris. Kenyatta National Hospital, you also have many students in training. How are they being roped in?
I think in addition to what Victoria has said, we also have, for example, we have a team on infection prevention and control. We have antimicrobial stewardship. And these teams the team comprises of staff from Kenyatta Hospital, and we also have a partnership with University of Nairobi. So we do have those who come in from the other institution, especially University of Nairobi, and that has helped us in terms of doing support supervision, where we also do participate in inducting also our students on what kind of quality programs are acceptable in Kenyatta and what standards we expect from them. In addition to that, they participate in the quality, the ISO 9001:2015 audits. We don't exclude them. So when it comes to sensitizing them and making them understand what quality management system is all about, they are also part of it. And so what has happened is that in as much as we have not been able to do committees with them and all that, they are inculcated in the same culture where we are talking about quality management system, and this is what in Kenyatta National Hospital, these are the guidelines, and this is what we. Thirdly, we have a committee which it's called a medical advisory committee. And in the medical advisory committee, it comprises of Kenyatta team, clinicians from Kenyatta. We have clinicians from University of Nairobi and also from the KMTC. And this multidisciplinary team will sit down to discuss matters to do with anything to do with quality in terms of how delivery of service is done. So in the event that there is maybe there's an error that has happened and something needs to be improved on, this committee is the one that sits and gives this advice. So you see, such collaboration brings about partnership at a level where we are looking at how are we managing the quality of care, of healthcare that we are giving as Kenyatta National Hospital. So we've put in some of those aspects where we are able to encourage them and also ensure that they are inducted into the KNH system such that they know how to document. Even here, the consultants are solely responsible. So every department, every ward has a particular consultant, and the consultant is responsible for the students. And so there is a guidance on how things are supposed to be done. So I think with those small inputs, at the end of the day, we are able to achieve what we would like to achieve in terms of quality of standards. Thank you.
Oh, that's amazing, especially considering that KNH is working as a partnership with University of Nairobi, KMTC. It's really impressive to hear how they are being roped in during the audits and all the quality programs. So you can raise your hand if you have a comment to make. I think there are some hands raised. You can still raise them again so that we can hear from one or two of the over 450 participants from across the counties. And as we wait for that, yes, many comments, a lot of comments that have come in, so many appreciations, powerful insights. Miriam Kithuka, Godfrey saying that KKMH implementation needs to be embraced in all aspects. That's Kenya Quality Model for Health is a ministry-backed quality system. Yeah, so I think there's still a couple of questions in the Q&A. Christine Echwa is asking, in quality improvement, what is the best approach for constant resistance to change? Maybe one of the panelists can pick that to answer. I could direct that to Dr. Lydia, and then either maybe Dr. Victoria, you could take this one from Juguna. How does your team encourage incident report without feeling as if they are being victimized? I know you touched on that, but maybe you can elaborate more. How are you avoiding people feeling coerced or punished? So, Dr. Lydia, resistance to change, how are you managing that?
Yeah, thank you very much. Resistance to change, it's constant. As Dr. Victoria said, quality improvement is the new kid in the block. And when you bring it up, people feel like you're adding them more work. They already have work. They already have so many things to achieve, and you're adding them more work. That they need to be doing these projects to improve their quality of care. Most of the time, what you get is what is the motivation behind it. But what we have learned is that you just have to keep lobbying and reassuring people that what they're doing is actually going to make their work more efficient and improve their patient's outcome. There is the good thing with healthcare workers is like they all wake up in the morning and they're in this field to make patient experience better. So as long as you can give them an initiative that is going to make their patients get the best experience and the best of their care and get the best outcomes, they are very willing. So that is the sell point, is like this, what we're doing is going to improve your outcomes and it's going to actually make your work more efficient with what you already have. That happens. But another thing that works is get feedback from the people on the ground. We have a system where people are afraid of individual blame. And as Doc said, we really need to start reinforcing psychological safety when we are getting feedback, especially from employees. People need to feel like if I report an error, if I report a senior colleague that might have put a patient in harm's way, I am going to be reprimanded for it. We need a space where there's psychological safety for people to say what I am reporting is just going to be used for improvement of the system and the quality of care of the patient, and not necessarily to point fingers at people. So that is the other thing that works. As my colleagues said, reinforcement, positive reinforcement works. Sometimes positive reinforcement is just having a poster of a colleague on the wall saying, these ones observed hand washing this week. You know, it is not the big things. It is the small recognition, the things that actually recognize people's efforts, and therefore they encourage others to pick up the pace. But as we said, there will always be outliers, but those who will come on board, and eventually you just have enough manpower to effect change. That's what I would answer on that question. Thank you.
Thank you, Dr. Lydia. So, Dr. Victoria, the victimization, how do we help staff to feel not victimized as they do instead reporting? You have a very elaborate system. Over to you.
Thank you for that question. So I think, as Dr. Lydia has said, culture takes time to change, and there's a lot of resistance. We must be very cognizant of that. But if we look at enabling culture of safety, one is having a simple reporting system, having it anonymized. I have the option of not revealing my identity. The other part is recognition, as we said, recognizing units or departments that actually do report incidences, having units do either quality improvement projects on culture of safety. But we are still cognizant that it takes time. Now, if we also go further and look at what culture of safety means, remember it's a double-edged sword. So culture of safety really encourages reporting, but is also non-tolerant to not reporting of errors. So let's say if errors come out through, as we said, social media, and the staff are actually not aware about it, then actually that does call into having individual accountability. So that then also makes staff feel that they have to report an incident, and when they report it, there's actually a systematic look into the incident and not rather saying it is you. And I realize us as the quality champions, there's a book I'm reading right now, actually, I was given, it's called Understanding Human Error. How we react to these incidents then does impact majorly how staff feel about reporting these incidences going forward. Are we judgmental? Are we saying you should have done this or done that? So with time, people get to understand that it is for their own benefit. Where challenges still exist is on the near misses, because then you find it has not happened. So you might not really get to know it almost happened, but regularly encouraging people and showing and sharing knowledge in terms of actually near misses are more important to report, because they do reveal potential weaknesses in the system or the process that has actually not been known yet to the rest of the teams. Thank you.
Thank you very much. That's quite insightful, and I think you've also given us a title that you can also read, Understanding Human Error. That's a very interesting book. So I can see, Doris, you have your hand up.
Yes, I just want to
Yes.
add one more point. Trust will always grow where there is communication. And so when we communicate clearly, and we are giving, like we are guiding, and we are clearly giving communication in terms of how are we relaying the information concerning where are we going, that breeds an understanding of, hey, this is the vision. And so what happens is that people will just run with it. But when we don't have good communication amongst ourselves, of course, there will be a lot of resistance to the change, and definitely we will not achieve what we wanted to achieve. So I think in addition to everything else that has been said, clear communication of what are we doing, why do we want to do what we are doing, really, really helps people to feel they're being treated fairly, and they're also being trusted in the process. And so when somebody feels trusted, then automatically will do what has actually been for them. Thank you.
Thank you very much. And so as we come to an end of this very exciting topic, I really want to thank the participants for such an engaging conversation this evening. I want to go around our panelists so that they can give their parting shot. I'll begin with Dr. Lydia, joining us all the way from Machakos. What is your parting shot on engaging staff? Yeah, Dr. Lydia.
I'll just conclude with a quote from John Ruskin saying, quality is never an accident. It is always a result of intelligent effort. So you need to reassure people that what they're doing is intelligent. It is science, it's actual work, it has an impact, it makes a difference all the time. We think of quality and think we're just moving things from here and here. It's the same things we've been doing over and over, just differently. No, we are measuring. We have process measures. We have outcome measures. We are balancing these measures to make sure that we're not tipping over and we're not influencing anything else negative into the system. It is intelligent work. It is making a difference, and to commit to it, then it becomes even better to enjoy this profession as we attend to our patients. Thank you very much. And thank you so much for the opportunity to be here tonight.
Wow, what a great parting shots. And we'd like to hear you again. So I move to Doris from Kenyatta Hospital. Your parting shot on engaging frontline staff in the quality agenda?
For me, my parting shot will be that people will always support what they help to build. So the key to us succeeding in matters to do with quality, and so that we can all feel, have this notion of it's not additional work, it is part of the work, and it is helping us to be more professional and to improve efficiency. If we are involved in it, we are happy when we are allowed to create it. We will own it and we'll run with it. So let us embrace that aspect of allowing ourselves, allowing our people, our teams to be able to create and to innovate, because it makes change easier and it makes implementation of quality standards easier. Thank you.
Wow, amazing. Co-create and it will just fly. And lastly, but not least, Dr. Nairuti, what do you want to leave with us this evening?
Dr. Kira, what can I say after the two great ladies have actually said all we could have said? But what I'll say is one thing I've come to agree with is that no staff actually comes to work with an aim to do harm or to produce healthcare that is of poor quality. And we must accept that frontline staff are the driving force for safer care. We might talk about quality, not about quality, but if they're not together with us, we are not going to move. Lastly, it's a very fulfilling thing, as you said, to be able to bring change, whether it's in the private sector, whether it's the public sector. Hopefully one day we'll be able to sit down and actually have conversations on how we can all work together, because the patients are the same. And for you and me, whether we get sick somewhere else, the nearest hospital is where we will go. So let's make quality and safety not an event, but an integral part of our everyday operations. Thank you.
Oh, that's quite powerful, and I could not agree more. Today I am posting this from Muranga County, actually, visiting a facility in Idanga. And those words you're leaving us, Victoria, actually, they are so true. In this level 4 hospital where I am at, they are really, that's the song here, because they say we are the ones sitting to cover ground. If you fall sick here, we are the ones to attend to you. Yeah, that is so true. So as we end the evening, there's an announcement from our hosts, that is the SQHK and KNH. Sorry, that's the wrong slide. So as we know, this is these webinars are actually a curtain raiser, or should we say a pre-conference series for the Society for Quality Healthcare Scientific Conference, the first one ever, that will be held this coming month on the 28th, Friday, November, at Pride Inn. So we want to engage more on this topic of starting where you are, build with what you have, quality and safe care for all, just as Dr. Victoria has told us. So those are the sub-themes. Quite a number of abstracts have already come in. The abstracts are still being received. So if you want to share your story, submit, and let's meet on that day to really learn what people are doing with what they have at the front line. So the charges are there. If you're a member, there's a subsidy. If you're a member of SQHK, and I think on the chat, the actual link for registration is being posted. Sorry, okay, pardon. Yes, so the link should be there. You can be able to just click and at least save it somewhere if you're not registered right now. But you can always just, yes, register there. So the link has been posted on the main chat. You can just save it. We'll leave it on for a few minutes for you to register. So let's see you on the 28th. We're really looking forward to this great engagement at the Pride in Azure, Nairobi. And I hand it over to the KNH team in case they have any announcement to make also.
I think we
So thank you
can
very much, all.
conclude.
Yeah.
Yeah, I don't think Mwenda or Nelson had any announcement. We are not aware of any, so I think Kira, you could conclude.
Thank you, Dr. Kutoi. Yes, so I conclude with thanking. We are really impressed by this large turnout, more than 450 people from around the country, almost every county represented. And as SQHK, we really want to make quality a national movement, a continental movement, and so that you can join the global movement in bringing the aspect of patient safety at the forefront. Thank you all, and do have a good night, and make sure you register with the link that is in the chat. Karibuni.